Good evening, ladies and gentlemen, and all the members of the Indian Orthodontic Society. Welcome to Ortho Illuminati, an international webinar series by the best orthodontists and clinicians world over. Organized and brought to you proudly by the Indian Orthodontic Society, where learning never stops. Sponsored by Elsevier. Hope you and your families are doing fine and are safe. I am Dr. Arjun Naik, Executive Committee Member, Indian Orthodontic Society. We start our lecture series today by a world-renowned speaker and a clinician par excellence, Professor Dr. Bhavana Shroff, Graduate Program Director, Virginia Commonwealth University, speaking to us about the management of impacted canines. Welcome, ma'am.
Thank you.
We would now like to start the program by seeking the blessings of the Almighty with a virtual lighting of the lamp.
Shubham kurutvam kalyanam arogyam dhanasampadah shatru buddhi vinashaya deepajyotir namostute o deepa brahma rupasvam jyotisham prabhuravyayah.
Thank you. I would now request our President, Indian Orthodontic Society, Professor Dr. Siljo Matthew, to kindly deliver the welcome address.
Thank you, Dr. Arjun. A warm greeting to one and all across the globe attending the webinar. Madam Secretary, Dr. Sridevi, immediate past President, Dr. Pradeep Jain sir, President-elect, Dr. Sri Krishna Chalsani, Vice President, Dr. Suryakant Das, all the principal office bearers, executive committee members, senior IOS members, especially the past presidents, Dr. Karbanda sir, Dr. G.K. Chandrasekhar, Dr. Gangadhar sir, senior IOS members, friends and students. A warm welcome to all of you to the first IOS International webinar. Before I begin, let me express my grief at the unfortunate Air India crash yesterday, wishing a speedy recovery to all the injured, and may the souls of the departed rest in peace. I welcome you all to the first lecture of the IOS International Webinar Series, a new initiative wherein every Saturday we bring some of the best names in the field of orthodontics, some of the best names in terms of research, clinical excellence from across the world. Happy to state that our first speaker for today is Dr. Bhavana Shroff, really a very popular person, a household name in India, among all the orthodontists as far as her work is concerned. And she has done pioneering work in three-piece intrusion arch, for which she's very popular in India, especially her work which was published in 1995 in AJODO. I welcome you, Dr. Bhavana. Interestingly, she is a native of Paris, a beautiful city. And as Dr. Arjun said, after her initial dental education, she moved over to US, first to Connecticut. From there, she moved on to Maryland, and now presently she is at Virginia Commonwealth University. I also appreciate the efforts of Dr. Sanjay Lab, who has really worked behind the scenes towards the organizing of International Webinars program for iOS. I would also like to appreciate the presence of some of the principal office bearers. I request you all to wave your hand as I call out your names. First is our Madam Secretary, Dr. Sridevi, and just wave your hand. Dr. Pradeep Jain sir, if you're there. Immediate past president, Dr. Shrikant Chalsani, President-elect of iOS, Dr. Suryakant Das, Yes, Dr. Surikanta Das, the Vice President, and Sanjay Lab, of course, the Treasurer, and Gyana Shanmugam, the Joint Secretary. Well, I won't take much of your time. We are all here to the wonderful lecture by Dr. Bhavana Shroff. So back to you, Arjun, for the continuation. Thank you and wish you all a great evening of learning and enrichment. Yes, Arjun, your mic is muted.
No,
Thank you so much,
so
sir.
thank you, sir.
I now call upon our Honorary Treasurer, Dr. Sanjay Lab, to kindly introduce our speaker for the day.
Right. So it's great pleasure and honor for me to present the most popular orthodontist, what many of us know her because of three-piece inclusion arch and other work in clinical orthodontics, Professor Dr. Bhavana Shroff. And already it has been told about her. She is professor and program head at Virginia Commonwealth University, Richmond, USA. She is diplomat of American Board of Orthodontics. She is fellow of American College of Dentists. She is member of AO Committee on Scientific Affairs and officer of the North Atlantic component of the Angle Society. Her research interests are mainly the fundamental mechanism of tooth eruption. Today, she is going to speak about the management of impacted canine. So I would like to present you the first speaker of the series, Professor Bhavana Shroff. And it is so kind of her that she has accepted our invitation in this period of pandemic during the lockdown period where we can share each other's knowledge. So it is so kind of her. My heartfelt thanks to her. And madam, the screen is yours now. Please share your screen now.
Thank you so much for having me, Dr. Matthew, Dr. Lab. Thank you for facilitating this. Dr. Sridevi, thank you so much for making this possible. It's really wonderful. I am so honored, so humbled, and so proud to be part of this journey with the Indian Orthodontic Society. And I want to really thank you all for inviting me because it means a great deal to me. It really does. As you said, I had an interesting journey. I was born and raised in Paris, and that's why I have a picture of the Eiffel Tower. May I ask if you can see my little pointer?
Yes, we can see.
Good, wonderful.
Yes, we can see.
Wonderful, thank you. So, you know, that's where I started. I had the great pleasure to come and study in the United States, and I'll say a little bit more about it. And I'm currently in Virginia. I am running the program at Virginia. And again, I am so grateful to be part of this webinar series. I'm going to share the stage with one of my esteemed colleagues who will speak in a few weeks, Dr. Tufekci, a dear friend from Italy, Dr. Perio, and probably, you know, another person that's very dear to my heart and who was an instructor, Dr. Varun Kalra. So thank you for having such a wonderful gathering of people. You know, I am most grateful. I know we are at a time of pandemic. I think it has been hard for the entire world, 5 months now, just going on almost 6 months in lockdown, partial lockdowns. Yesterday, I was very saddened by, you know, the news of the Indian Airlines plane crashing. You know, I think most people survived, which is good. They were coming to see their families. And I think it's wonderful that we can all gather and learn a little bit, and for maybe an hour and a half, forget a little bit about the challenges of the world today and concentrate on something that is really our passion. So this morning, what I would like to do, I would like to talk about the management of impacted canines. And it's something that I really enjoy in the clinic. If you ask my residents will tell you that I really enjoy that. And before I get started on my topic, I wanted to share a little bit, a few pictures from my past, at least my past in the United States. I arrived in the United States in 1986, and that dates me a little bit. And I want you to recognize here Dr. Burstone. He was on sabbatical in Germany. This is Dr. Burstone when I was a resident. For Christmas, he would always dress up as Santa Claus. And the year I graduated, we went with Dr. Lindauer, who is here opening his Christmas gift as a resident. We went to visit Dr. Burstone in Germany after I graduated. 20 years later, we had a reunion in Richmond, and you can recognize, of course, Dr. Burstone is here. Dr. Lou Norton was my program director, and I owe both of them a great deal. Of course, you recognize me, Dr. Lindauer, and Dr. Cindy Beeman, and we all decided to teach. And we are all teachers, and we've been doing that for quite some time. Now let's get back to the topic of the day, and the topic of the day is canines. And one may ask as a clinician, why is it that impacted canines are a challenge? They are a challenge. That's what we do every day when people come to see me and say, my child has an impacted canine. I, always say, well, that's what we do, and orthodontists are known to be good at that, and it's part of the service that we offer. Impacted canine, if we look at the literature for maxillary canines, are observed in about 2% of the population. Of course, if you are looking at your practices, it's going to be more than 2% of the population because they're all coming to see you. And so, it's a very interesting malocclusion. It's challenging, and I'm going to try to give you some help this morning on how to approach it and how to be successful with the outcomes. We know that about 80% of them are going to be palatal, and about 15% are going to be labial. They happen twice more commonly in girls than in boys, and this may be due to the fact that we have more young ladies come seeking orthodontic treatment than boys, but that trend seems to level up. 8% of the canines are going to be bilateral, and they're 5 times more common in Caucasian than they are in Asian. That is not to say that it doesn't happen in my clinic, which is a very diverse clinic. We have lots of patients that come with impacted canine, and our role is to help them diagnose and treat them, so we offer them wonderful outcomes. We know that the palatal impactions are multifactorial, and they have a polygenic inheritance. That means that there are several factors that are involved in the palatal canines, in the occurrence of those, and probably some of it might be of genetic inheritance, but we're not sure at this point exactly what it would be. One thing that we know, though, and that's something that's very important, is when you look at labial canines are usually going to be associated with crowding. But palatal canines are usually not associated with crowding. And that is something that is, really interesting. And although we do need to make a little space for them, they're usually not going to be badly crowded. So once this is all done, one may ask, so, this is all nice and good. What is the challenge? So the challenge is several folds. The first one is a difficult treatment, a treatment that is going to be longer. On average, if somebody has, an impacted canine, you can easily and very simply tell them right up front, their treatment is going to be about 9 months longer than average treatment if they didn't have an impacted canine. So it gives them a sense that if average treatment is about 24 to 28 months, you can tack on it another 9 months just to bring that canine. So long, challenging treatment. A challenge is also surgical intervention. Most people who come to see us are not going to think surgical intervention. And I think that that's something that we need to educate patients. I mean, for kids that are going to be 14, 15, even, surgery to expose a canine is surgery. And it is going to be something that is going to be a challenge for the families, for the children. So there is a challenge there. There is a challenge with the mechanics, and that is going to be towards the latter part of the lecture. It really is something that is important. We don't treat every canines the same way. We have to really be very specific about the diagnosis and our goals so that we can have the right mechanics. And then, unfortunately, we may sometimes have iatrogenic sequelae. A canine that seems to move okay is going to continue to move, but the outcomes, and especially the aesthetic outcomes, may not be the outcomes that we want. So, lots of challenges, something we deal with every single day in our practices. And I think that, that is why, canines are still something that may be a little intimidating to some people. For me, I love them. I really enjoy them. And it's really something that, I like to treat in the clinic. So what do we do to optimize the outcomes? The first thing is we need to know the position of the impacted canine. That is something that is very important. We're going to, talk about it quite a bit because today is very different than it was 30 years ago. When I was in my residency, there was, the impacted canines. We only had some ways to look at their position. And, primarily it was a 2D diagnosis. Today, we're very, very lucky to have, a diagnosis that we can do in 3 dimensions. The exposure of the canine is going to be another part that is going to be extremely important in optimizing the outcomes. I think again, and I'm going to repeat that, along this lecture, all canines are not the same, and we cannot send to our surgeon or our periodontist a blanket statement saying expose the canine. I think the exposures are different for the different types of diagnosis that we come up with, and we as the orthodontist need to be very, very specific on, what do we do, how do we do it, and, what we request from the surgeon or the periodontist. What to ask the surgeon? We have to be specific. What do you have to consider before the surgery? And that is going to be primarily periodontal concerns. And I think that today, the days have changed. We cannot just, have one prescription that fits all. I think the third challenge that is quite a bit of a challenge is the movement of the impacted canines. And the movement of the impacted canine is something that we are almost totally in control as an orthodontist because we know biomechanics. I have learned biomechanics with Dr. Burstone, and I'm forever grateful to him for teaching me what I know today. And the movement of the canine, if we have the proper diagnosis, and it's going to be a 3D diagnosis, we should be able to figure out what we want to do. So we will decide on the direction of the force. We will decide on optimizing the movement. And we're going to also decide on what can be the potential undesirable side effect, the side effect that we do not want, and the side effect that we know how to avoid because we know our biomechanics and the things that we should do and the things that we clearly should not do. So this morning, the idea is to embark on this journey And we're going to start to talk about the position of the canine. We will talk a little bit about the exposure of the canines, and then we'll conclude by talking about biomechanics and what to do. If you went to school like, some of us did, about 30 some years ago, 3 decades ago, when I was in my residency, the classic approach to diagnosing a canine was you would take 2 periapical x-rays at different angle. You would look at them and you would do, the swab, the rule of looking at one and the other, and you would try to, figure out where the canine was. You would have some ideas about, where it was, some, fairly good ideas. But one thing that you really could not determine very well is what about the other teeth, the teeth that are around the canine? We also took panoramics, which we still do today. We took frontal x-rays in those days, and the frontal x-rays gave us a very good idea of the inclination of these canines in the transverse dimension. We took cephalometric films, a standard approach to orthodontic treatment. So we had an idea how high the canine was. And then we took the infamous occlusal film, and we would have a better idea of where the canine sat. And then with the computers that are in our brains, we would try to put together a 3-dimensional picture, and we would come up with a diagnosis. Today, we have cone beam CT. And for the younger orthodontists in the crowd, you are so lucky to have that technology. I love that technology. And I do have to admit that if I knew 30 years ago what I know now, I would have been pretty scared about embarking on some of the exposures that I embarked on, and they turned out well, but I would have a lot more knowledge. And knowledge is, freedom and the power to control what you're going to do. And it's really, it's really a great feeling. So this is a typical, foreview of a cone beam CT. At VCU, we do have cone beam CT that we do systematically on every canine. And when you see something that looks like this, and we're going to look at many of those, you kind of get a bit nervous. Personally, even after all these years in practice, I look at this, I pause, and then I'm like, okay, let's work through, the checklist, and let's make sure that we approach that correctly, because it's important, it's critical. So when we determine the position of a canine, what are the elements that are really important for us? The first is the position of the canine, and although it seems very, simple to say, well, where is the canine? Well, of course, where is the canine? We all want to know where it is, and if it's a maxillary canine, we know it's going to be somewhere in the maxilla. But it's important to pause and say, the canine is here, and then how favorable is the position of the canine? So we do want to know the inclination of the canine, where is the root, where is the crown, and we do want to think, all that information is nice and good. It's going to be important for the surgeon. It's going to be important for the surgeon who bonds something on the crown of the canine, but it's going to be critical for us. Implication for our mechanics. If we don't know these things, we cannot move the canine. It's almost like, you would be moving it blindly, and nobody wants to do that. I certainly do not want to do that. So how to determine the position of the canine? I think the position and the inclination are at least 2, factors that are absolutely critical, and we are going to look at some more. So when you look at a picture like this, you can see on the cone beam CT that very clearly you can see where the canine is. You can look at the canine in many space. You can look at it, from the occlusal, and actually you can move it back and forth. We will see if my animations are working. You have the axial inclination, where is the root, where is the crown, and then you know where it's going to be in respect to the other teeth. And that is critical because in this society that is very litigious, we want to make sure that our patients are aware of, there is damage to the teeth, there is potential for damage to the teeth, and this is the probability of this happening. We just can't tell them, we're going to erupt the tooth and we're going to see what happened. Those days are gone, they're long gone, and even 30 years ago, we didn't do that. We knew better, and there is, quite a body of evidence that, can help us with that. I think how to determine the position of the canine, we need to find out what is the relationship to the other teeth. Primarily the lateral incisor. The lateral incisor is a very, a very fragile tooth. The root of that tooth is very thin, and you want to make sure that if the canine is in relationship to a lateral incisor, you are extra careful. We're always extra careful, but we want to be even more careful and aware. And most importantly, we want to tell the families and let them know. You can show them in real time on an cone beam CT what the issue is. You want to know the proximity to the teeth, the other teeth, and which ones. The lateral incisor is your natural, but you also can be in proximity to central incisors. You can be in proximity to premolars. You can have also teeth that have been transposed. We have had, a few examples of those. And one has to know, and again, doing your due diligence will help you long term. The next important factor in determining the position of the canine is to ask yourself, is there enough space to move the canine as we erupt it? Is there enough space on the arch? Is there enough space to maneuver the canine? Because, for a while we are going to work sort of blindly because the canine is indeed impacted. And you need to make sure that you have a plan. So you have a roadmap of where you're going to take that canine step by step. It's very critical. You need to also make a note very carefully. Is there damage to the teeth in proximity to the canine? You have to know that. You have to inform people because it's really, really very, very critical. In United States, we see situations where people have not been told, and at the end of treatment, it is realized that people are going to lose maybe a lateral incisor, maybe central incisors, just because the canine might have made damage to begin with, but nobody ever told them. So it's critical. And then the other fold is, as you move the canine, are you going to actually run into other teeth and creating some damage? So, by the end of that list, if anybody is still willing to move canine, it would be amazing. But the good news is, yes, we can do this and we can do it safely. We just have to be careful about it and go and do our due diligence. This is not quick treatment. This is not standard treatment. This is intelligent treatment that orthodontists are able to do day in, day out. I think once we know all that, it will definitely determine our mechanics. And mechanics is everything, and design of the appliance is everything when we're dealing with anything in orthodontics, and probably canines more than anything else. So let's look at a few examples, and let's look at some canines. And I'm going to point out to some of them that, seem okay, and some of them where we're really like, oh, thank God I saw that. Thank God I know, because, could be an issue. I always tell my resident, if a child approaches the age of 12 and the canines are not on the arch, it is our duty to take the imaging and find out. Too many times I see children that are referred to us later, and unfortunately, because they come later, it's going to make our journey a little bit more complicated. So if we look at this one, this is a child that has an impacted canine, as you can see here, and it looks like it, is not in bad position. It's not too high. It's, should be fairly straightforward. If I look at it in this view, I can see that it's not too close to the lateral incisor. If I move it back and forth, up and down, I can see that there is no real damage to the lateral incisor. And I can also tell that the inclination is good, it's favorable. This is one that I am going to still be very careful about, but I know that, I'm in fairly decent shape and I can move along. Now, every time I'm going to approach a canine like this, I still have to be careful about that lateral incisor and that premolar and make sure as I start to line up everything that the roots are not going to come in contact with the tooth. But we'll talk about that. I think this one may be a little bit more challenging. We can see this canine sitting right on top of a lateral incisor. So here I really need to look at relationship with the lateral incisor, and I need to look at the risk. I need to go back to that cone beam, move it back and forth, and make sure that I don't have damage to that lateral incisor. The canine might just be sitting on top of the root with no, resorption of that root. But on the other hand, it could be that there is severe resorption. And if the resorption is that severe, it may change my treatment plan. So, it's important, and it's something that we really need to be careful about. If we look at this one, and I'm going to put it in motion for you here, you can see that the canine is palatal. The canine is in relationship right here with the palatal side of the lateral incisor. And this is something that, we need to be thoroughly aware. I'm going to, walk it back again just so everybody gets a chance to see it. But this is something that we really need to pay attention. When the surgeon is going to intervene, the surgeon can give us a direct view picture of what they see. Also, it's something that, can be of use to us. If you look at this one, other canines, these are impacted on the labial, and, let's take a look at them. And, we can move them around. We are a little bit concerned about this area here, this area here. And, we have ways that we can slice our cone beam and look at them. But when I say we need to look at the teeth, where they are and how they relate to the other teeth, I'm not joking. Let's look at it again just to make sure that lateral incisor is high risk. That central incisor and that lateral incisor roots, they're very high risk. Again, a situation like this may be so severe that it is going to change my treatment plan. So, rather than maybe erupting those canines, I may, think about something else and say, let me have, some other plan. Let's look at this one here, and we're going to look at it in two planes so you have a better idea. Here you can see the proximity on one of the tooth, and we can see the proximity on the other. I'm going to play it again just so that, everybody sees it well. But this view is going to be critical for us to assess. And sometimes the canine is going to be very, very close, but no damage, we can move forward. So, you have to keep it in mind. We have to do our due diligence. Let's look at this one again from another view. And let's look at this And you can see we're going, we look at the canines here, and they're coming in relationship on one side, it's very close, on the other side also, and we go back and forth, and we're looking at these teeth and looking at, how they relate to their surrounding. It's absolutely something that needs to be done. Let's move to this one. This is a very severe case, I have to say. And let's look at it. And you can see the relationship with the central incisor, the lateral incisor. I think that for this, unfortunately, we all know that there is quite a bit of damage to the teeth that are, anteriorly positioned, the lateral incisor and the central incisors. Now here, we're back to, the situation where we had a canine that was wedged between a central incisor and a lateral incisor. And here I'm just showing you the relationship with the lateral incisor here. Here is the relationship with, the lateral incisor from the frontal view. And here is the relationship with the central incisor. So really, the dynamic of this is critical. And I can tell you that looking at this is really a treat for me. But I thought, my God, we used to just look at a panoramic, few PAs, and move in there and move the canines. And, we only saw probably 75% of the picture. Now, if you look at this one here, we can see from the outside the palatal position, the proximity with the other teeth, and look at this from, the palate, we can see there is a relationship with that lateral incisor, maybe even with the central, and I think that it's, quite critical, and we really, really need to be aware of that. It's not just the legal aspect of it that is important, but really the well-being of our patients and our mechanics. Knowing this, we are informed, we can inform our patient, and we can all make an informed decision in going forward with treatment. We may have several treatment plans that we can offer. It happens very often in my clinic, and we decide with the family, we provide the family with help in, how to do this, how to decide what's going to be the best for the family. Look at this one too. You can see the inclination of, the canine. We can look at the crown position, the root position, and this one actually may be favorable for the inclination because the root is where I want it. The crown has to be moved. I just have to be very careful about these anterior teeth. And, the cone beam is going to tell me exactly where they are, if there is damage, if there is no damage, and I'm going to make the mechanics decision that I need for that. I think, this is, another one that is, quite some things. These canines are on the buccal. You can also see the amount of bone that's available on the buccal. This is important for your periodontist. Look at this one. This is going to be complicated in terms of outcomes. And, you want to have a better idea of, okay, what does it contact? The root of the lateral incisor, is it in contact with, the premolar? Is there enough space? You are going to be able to diagnose all of this with a cone beam CT. In my clinic, we take cone beam CT systematically on anybody who has an impacted tooth at no extra cost to the patient because we feel strong that this is something we need for the diagnosis. Here is another one that you can see. Look at the proximity. I mean, it's amazing, and we can look at it in all planes of space. So, the inclination of the tooth is very favorable, but really, what is a bit of a problem is the proximity, to the other teeth. You want to know if the root is in a good position, and here it would be. You don't need to move that root, hopefully. And you need to know whether the crown is a good position. So if the crown is actually more buccal, it's easier for us. If it's more palatal, it is going to be a little bit more challenging. As long as we know, we're going to design our mechanics to serve the purpose. Now, when we're going to look at canines, and this one is probably the scariest of all my collection here, maybe not the scariest, but one of them, we have to figure out if there is enough space for that canine, because although that's not the primary etiology of why the canine is where it is, we need the space to erupt it. And then during our treatment, we need to sequence the eruption. So here we have two premolars coming at each other. So we're going to have to take care of that before we even start to move the canine, because the proximity of the canine to the anterior teeth and the root of that premolar is such that, you know, it's a jam. They just cannot move. So sequencing your treatment is also going to be something that, you know, we need to do. Here you can see the same, you know, image and the proximity, and it's close. It's very close. So we're going to have stages of treatment where we say, okay, let's do this first, and then let's move on to that. And that will take time. It will take effort. And that's what we do when we design, you know, the appliances. And we'll see that in a moment. Here is another view. You can see, you know, how close it is to the premolars, and you know, it's challenging. There is no question about it. So teeth proximity, damage, do you have enough space, inclination of the canine? That should be really automatic things that we think about as we go through looking at a cone beam and evaluating the situation. You need to sequence the treatment. I think that's something that's very critical. And, you know, different patients will have different sequence in treatment. We are going to see here a canine that is very close to, you know, the incisors, and that is going to be an issue to move the canine. It's going to be an issue to move the incisors as well. So we really need to put our thinking caps on top of our heads. So now that I've showed you a number of impacted canine, let's move on to number 2, the exposure of the canine. So by now, we all know where the canine is. We have all the information that we need in terms of, you know, the inclination, the proximity of the teeth, even if there was any pathology. We know if there is damage to the surrounding teeth, and we also know whether we're going to need to open, you know, space. Now, one thing is very important about the exposure of the canine is whether it's palatal or buccal, it's going to be different procedures. And different procedures are going to have different periodontal concerns. Part of our treatment is, of course, to successfully bring that canine onto the arch, if we decide to do so. But a big part of our treatment is also to give optimal aesthetic result at the end. So optimal position of the canine, optimal periodontium to support it. So if we think about close exposure, if they are on the buccal, we are going to need at least 2 or 3 millimeters of keratinized tissue. And if we don't have that, we have to do apically reposition flaps. It's something that, you know, is going to take, you know, surgery. It's more procedure for the child, but it's really something that we need to do. If we do a close exposure on the palatal side, you know, the palatal side has that thick keratinized tissue, there are a few studies that have showed that it will lengthen the time of treatment. So on the palatal side, whenever you can do it, do an open exposure. Vince Kokich Sr. was the one that first talked about it in the early 90s, and he was right. It will work out beautifully, and it will allow the patient to have better hygiene, shorter treatment time. You may not even have to start to put appliances right away. Expose the canine on the palate, open exposure, your periodontist will do an ice pack, let it erupt. It will make things easier for you. The periodontal concern with the buccal canine is the amount of keratinized tissue. It's critical. And I'm going to show you an example where, we didn't quite succeed, and we know why we didn't succeed. And the position of the attachment is also going to be critical, because that's the point of force application. And it's really something that, if your surgeon or your periodontist puts it on the lingual, it's going to be a little bit of an issue. You need to know. So let's look at some cases here, and let's look at situation. Some of them have gone very well, some of them perhaps not so well, and let's try to learn from it. So this is a canine that is buccal. It doesn't look so bad. Here is actually a panoramic that is taken from a cone beam CT. So, we looked at the cone beam, we're happy with it. We set up everything, to bring the canine. We're making the space, and, it was supposed to be a closed exposure. And the closed exposure actually comes back to us as an open exposure. This was supposed to be a closed exposure because it's so high. There is really not that much keratinized tissue. And really what we need is to do here an apically positioned flap. So, on that patient, unfortunately, it didn't happen. We did erupt the canine, but look at the outcomes. Look at the outcomes here in terms of the periodontal, assessment. This is not something that we accept. Now, luckily, the patient has a low smile line, so it doesn't show very much, but it's an issue. It's an issue, and it's really something that we do need to be very careful about. So here, on the contrary, we have a patient that has 2-3 millimeters of keratinized tissue. We are going to set up everything with the buccal exposure, and things are going to look good. Here we have, gingiva that is really, looking good, except for the inflammation that we have because of, the plaque and the braces. But overall, it's good. It's going to be healthy, and aesthetically, it's going to be a nice outcome. Sometimes it can be a lot more complicated. If we look at this one, clearly the canine that you see here is pushing on that central incisor. It has also deflected the lateral incisor. This is a panoramic that is taken out of a cone beam, and this is challenging. This is complicated. So for a canine like this, it's so high in the vestibule that you really want to do an apically repositioned flap, but it's so high that the periodontist is like, listen, I can't do it. I can't do it because it's so high. I need that canine to move occlusally a little bit, distal a little bit, and then I can do an apically positioned flap. So first, what we're going to do is move that canine, slide it very slowly distal with a cantilever. And then when it comes down occlusal, the periodontist will take care of that and do an apically positioned flap. It is critical because it's more time, more surgery. The patient needs to be on board. The patient needs to be aware of this. Now, if we do look at a patient like this, these are canines that, are coming buccal. We're setting up the patient, to get, the exposure. And then our periodontist is going to do an apically positioned flap. So they're going to make sure that the keratinized tissue that's here is going to be coming down with the canine when we start to erupt it. So this is what it looks like from a periodontist standpoint. And I think for us at VCU, some of the canines, especially the buccal ones, we're going to send them to a periodontist because, the periodontist just handles that tissue better. They just know how to do this because that's all they do. Surgeons are going to be, approaching it a little bit differently. So, it depends who is your, person that you can, send it to. The patient heals well, you can still see, the trace of, the flap less on this side than on this side, but usually it works very well. And you can see that one canine is coming with an overlay and a bypass arch wire. The other one, we just put the wire on top of it just to put a force and bring the canine down slowly. And then we're going to take them into the main arch wire. And we will talk about mechanics in a few moments, so rest assured we'll go over that. I think that, here we have a situation that is complicated, it is challenging. Canine is sitting right here, so it has put pressure on that lateral incisor, and you can see how the lateral incisor is. And, this is a situation where we're going to set up our patient with our mechanics, and we're going to, bring the canine down very slowly, making sure there is enough keratinized tissue, and then we're going to use a bypass to bring it down. But, in a situation like this, the periodontist is going to be involved, and at some point in time, they will need to intervene and do an apically positioned flap to save that keratinized tissue. Now let's look at the other side, and let's look at the tissue on the palatal. And I have showed you some of them. No, sorry, this one is still a buccal one, and it's another buccal one with a and look at, we have to do it systematically, and it's, it's part of the diet. And it's part of the recommendation. Is the science telling us about this? So Cassina in 2018 did a systematic review on open studies. They were unfortunately most of them prospective studies. Some of them were randomized, but it's more complicated to do. And they had a total of 333 patients. So quite a bit of data. The results were fairly clear. If they did an open exposure, they would reduce time of the canine for alignment by about 2 months. So it's not so bad. If they did an open exposure with no luxation of the canine, they had better odds of not having ankylosis of the tooth. The canine position does matter for the length of treatment. So as we said, it is going to add some treatment time. And the palatal canine will usually take a little bit longer to erupt. They think about 8.8 months. When I said at the beginning, count about 9 extra months of treatment versus 4 months if you're looking at some canine that is buccal. So the conclusion is, an open exposure, is it really superior? And in some cases, it's clearly the way to go. And that's something that you as a clinician, you as a specialist, you're going to do the diagnosis and you're going to make that recommendation. Let's look at science. A paper from 2006 review, 91 total studies. They only selected 3, and what they looked at is the the uncovering, and they said that if you use excisional uncovering without being careful about that keratinized tissue, you had more bleeding, more gingival recession, less keratinized tissue. And really, if you did a apically repositioned flap for buccal canines, they would come out, exactly as a normal canine would come out. So they were very comparable to a site that isn't treated to a control, which is very good for, the procedure, because it means that it really is, quite superior. So, I think, there is not a ton of evidence, but there is some guidance. And, any systematic review is going to conclude, we need more trial, we need more evidence, but I think we know better. And today, if somebody came up with a high canine and we don't do an apically repositioned flap and somebody uses a laser in their office, it clearly would be something that would go along with malpractice. So, something to think about and something to really apply in every orthodontics. So you look at, palatal canines, the depth of the impaction is going to, be important on whether you can or you cannot keep it open. You need to make sure that, the bone doesn't grow over it, and that the tissue, the soft tissue doesn't grow over it, and then that the attachment is not loose. So many times in the day of, bondings that were not as strong as they are today, we had chains that would become loose. Today, the bonding is excellent, and as long as you can provide a dry field, that bonding will stay on forever. We can look at, where the canine is located on the cone beam, and we have a good idea, and this is going to help us decide what we do. And my residents here are looking at this case, and they're looking at this. Then they see that, somebody has done, somewhat of, maybe a closed exposure, but it's kind of a semi-open closed exposure. It's open here, and then, there is something, the palate, the soft tissue grew. And then finally, we were able to get a clean exposure, and we bring the canine into the arch. And my residents are asking, well, would an open exposure have made things easier? And my second years is saying, yes, of course it would have. It's a lot easier to clean, it's better, it's gonna be faster, and it's less painful for the patient, because look at how the tissue heals nicely around the canine. So I think, again, you do have factors that you have to keep into account, but it's totally feasible. And, we're the people driving that decision, and we're the people saying, listen, this is the way, we need to do things. So if we look at this one is clearly impacted, the other one is actually lingually, palatally positioned, and we're going to expose one and then, bring the other one. One is going to be brought by a cantilever from the buccal. The other one is going to be brought, distally away from the lateral incisor, here too, away from the lateral incisor, and then only brought into the arch. So we're really going to look at everything together and be very careful to protect not only the other teeth, but also how we move the canine and where we move the canine. I think that, I've given you elements for diagnosis. I've given you elements to talk to your surgeon or your periodontist. Now, in the last part of this lecture, let me give you some elements about biomechanics. I think biomechanics is something that is critical to know, and it's, critical for us because it will help us define where the canine needs to go. I think it's very critical for us to decide when we have diagnosed the canine is in this position, and this is the movement that I need to do. For instance, you say, I want the canine to move occlusally and distally. And I'm not saying how I'm gonna do it, but I know that that's what the sequence of event that I want. So the direction of the force, the direction of what we are going to do as orthodontists is absolutely critical. We absolutely have to know. The position of the canine, of course, is going to help us determine, the force system, and the force system is going to help us determine what is desired as tooth movement and what in some cases may not be so desired and may be undesirable side effect. This is a case where we can see a Kant, first years, orthodontic residents are very eager to put braces on every single tooth. It's normal. They are excited, they're passionate, they want to do it. And, I discussed one, as a matter of fact, yesterday morning with one of my residents, and he's like, I'm going to put brackets on every tooth, and I'm going to put a very light night tie that's going to go in all these teeth. Well, if you do that, essentially what you're going to create is a cant. This is not too bad of a cant. We have seen worse, but I didn't want to, scare people. We do not want to create them. But a cant is going to show, and it's going to show even worse when the patient smiles. So that's not something we want to do. So how does it happen that we create a cant, for our patients? So let's go through that before we, embark on mechanics. So let's say that I have a high canine here, and I decide as a first-year resident, I'm very eager to get started. I am going to put brackets on every single tooth on this arch. And, I'm going to assume that if I put a wire through it, all that's going to happen is the canine will come down. Well, that's one of the things that is going to happen. But what is also going to happen is I'm going to create an open bite in that area, in this area right here. And the entire occlusal plane here is going to rotate around the center of resistance of, that maxilla. So the result from here, I am going to get to here, and my patient has a cant. Now, on top of trying to bring that canine down, I have a cant that I have to correct, and that is going to, ask for lots of work, and it's going to make the length of the treatment significantly longer. So, what do you do in order to avoid that type of thing? You look at your diagnosis, and the first thing and foremost, the direction of the force. You need to know what to do to move the canine and protect, the other teeth. So if I look at a canine like this, and I know my diagnosis from the cone beam CT, I know that I need to move that canine away from these anterior teeth. I know I have to do that. And in order for me to do that, I am going to say, first thing I want to do, I want to move the canine distal and then occlusal. If I move that canine occlusal, there is a good chance I'm going to continue to damage the teeth here. Same for that canine here. It's the same, process. You need to move that canine with a simple distal force. And the other thing that's very critical, I do not want to move any of those teeth. Don't start to align them. I don't need their alignment at this point. So people may say, oh, but the patient would like to have straight teeth. Well, that is part of what we explain to them. In order to move that tooth safely, I need to leave the teeth that are here just the way they are. So at least I can control it and I can move that canine out of the way. If you look at strategies to do that, you may ask yourself, do I want to use a cantilever or do I want to use a straight wire? And the choice is yours as long as you know the biomechanics. It's all about controlling the anchorage. I think if you go with, some kind of spring as you see here, or cantilevers that are coming from, the palatal, or even you've seen pictures before of cantilevers coming from, the buccal, that's possible. It's all about anchorage. And in those pictures, my anchorage is going to be the entire arch and a palatal arch. So I have a rigid unit that is going to provide anchorage for me to pull on these canines. If you're looking at this other situation, you have, a situation where you're going to have a spring and, a very rigid arch wire that goes all the way around, or you're going to have an overlay up to the canine. Again, you're going to need an arch wire that's going to be very rigid in order to provide anchorage. So decide according to the slot size that you use, the appliance that you use, what is going to be for you the best way to control your anchorage. It's really critical. My residents agree, and they're talking about cantilever because they do like cantilever. This is not a montage. This is a true picture. And you can see here, you can have cantilevers that are running from, the palatal. You can have cantilevers that are running from, the occlusal, and you can use both. This is a case where the patient had severely resorbed anterior teeth. We don't want to touch them, just bring the canines onto the arch. If you look at the situation here, this is going to be a closed exposure. We're going to bring, the canine down through the tissue. So we have that good keratinized tissue, and we set ourselves with standard anchorage, palatal arch, rigid bypass arch wire. You can see that bypass arch wire, and we're using, a very light arch wire to start to bring, the canine slowly down onto the arch. So, that works very well. Again, the key to what you do is the direction of the force, and it's going to be your anchorage. If you look at this cone beam CT will tell you what to do in terms of moving that canine. You want to move that canine distal and occlusal. If you move it occlusal and distal, you're going to run into, the root of the lateral incisor. If you want to create space, you need to make sure that the anterior segment is bonded passively, so the root of the lateral incisor doesn't move into the crown of, the canine. If you look at this situation here, you got a canine that is, palatal. Is this something that we could do with a laser? Probably so. It's very close. It's, there is no bone. Only embark on doing that if you're sure. Some of my, very, very young residents that are just starting, they've been in the program for probably just a few weeks. They're like, oh, I want to use the laser. Well, during a time of pandemic, they cannot use the laser. So that's one thing. But if the tissue is too thick, they might get surprised. And they may be like, oh, I thought it would be easier. And really, it didn't turn out to be that easy. It's, so you have to choose wisely. If you look at, this, you can see the canine here underneath the tissue. It was exposed. You bring the canine and you have to check, the torque on that canine. This is something that you will have to correct, and you can either incorporate some torque, which is going to correct that canine, or use, a torquing spring for an appointment or two, and it will do the trick. But you have to do something, because otherwise those canines are not going to be stable. They're going to move back just a little bit as soon as your patients go into retention. So be careful, be aware, be informed. Let's look at this situation right here. You have a canine that, is coming buccally. The tissue is, looking good. We are starting by just bringing the canine down, and we're putting a wire on top of the bracket. It is a single force into, on top of the canine. And as we go, we are going to have, the wire go into, the slot of the canine, and we're going to align it. So again, you are in control of your mechanics. Use that control to do good, because we can do it. As I said, knowledge gives you the freedom to choose, and knowledge gives you a lot of power to really give beautiful outcomes for your patients. We're coming to the conclusion of this lecture. And as a conclusion, I think there are three things that, if anything else, I would like you to remember. The diagnosis is critical. And for those of you who can actually get a cone beam CT, please do it. I think that today it will give you so much good information that it's not, it's not even a question. You are going to give a little bit more radiation to the patient, but not that much more. And I think the risk benefit is clearly, a benefit to the patient. In terms of the exposure, please make sure that there is enough attached gingiva on the buccal aspect. The 2 to 3 millimeter rule is one of the few rules in orthodontics, but you cannot violate that, because otherwise over time, you are going to have aesthetic results that are just not going to hold. If you are on the palatal side, try to do an open exposure, try to request an open exposure as often as you possibly can. And the last thing is, from a biomechanics standpoint, control the anchorage. That is critical. You absolutely need to control the anchorage. You need to, to have a good idea of, you need to predict what the movement is going to be, to have a good idea of what you want out of the movement and what you do not want. So, if that's the case, you can probably limit the undesirable side effects that, you could get with some appliances. I want to thank everybody for their attention. I think we have almost, 650 people that are here on a Saturday evening in India. It's mid-morning for me here in Richmond, Virginia. And I want to thank the Indian Orthodontic Society for having this webinar series. Again, I'm so honored, I'm so humbled, and I'm so proud to be part of it. Thank you for having me. It's a real honor. It's really something that I will cherish during my entire life. And I also want to thank all my residents that are probably working on their treatment plans as we speak, because I met with them yesterday and I will meet again with them Monday. And I want to say to all the young orthodontists that are in the field, you inspire me every day. I have learned so much from the young orthodontists in the fields, and you have helped me so much with technology, and I've always been very grateful. So thank you all for your time, for your attention. And as we say here, we're in this together, hashtag alone together during the pandemic. We will get through this. Thank you so much. Thank you very much.
Thank you, Dr. Bhavana, for a very, very enlightening lecture. I think when people come to listen to you, they expect biomechanics, and you didn't disappoint.
Thank you.
You touched on a variety of things, location of the canines, exposure, biomechanics, with a wide gamut of excellent clinical cases. Thank you so much.
You're very welcome. Thank you.
Today we have students, we have practitioners, we have very senior practitioners, but I think everybody got something out of your lecture. And on behalf of the President of the Indian Orthodontic Society, the Executive Committee of the Indian Orthodontic Society, and the entire membership, it's my privilege to present you with a virtual certificate of appreciation.
Thank you so much. Thank you.
Sending to you by email. I could have given it to you physically, but I'm sure we will have other opportunities in the future. So thank you so much. Thank you so much.
Thank you.